The goals of this particular component, which started quite a while ago in September 2016, was to identify needs, barriers, practices, and recommendations existent in the literature on palliative care since 2005. So we went back to 2005 because of Hurricane Katrina, and that's when a lot of discussion was published around whether or not palliative care should be something that we prepare for in light of the controversy around what was framed as euthanasia at least, and some legal proceedings after that incident. So we searched five indexes as well as ReliefWeb and IGO for gray literature. We triangulated the search with a number of organizational websites, and this has been published, so you certainly can look at the methodology. But just to give you a sense of why this took so long, 14,000 records, eventually led to 95 sources being included in our lit review. They had to deal with a low or middle income country context and discuss palliative care or end-of-life care explicitly. Okay, so what are the main findings? One of the things that was striking, and that actually Dr. Bezanson pointed out early on, is that there were no articles that talked about palliative care in famine, which is really striking given the high mortality rate in context of famine. So that was an absence that was notable, since we were looking for absences as well as trying to describe what was present in the literature. In terms of also emerging is really the challenge of defining who requires or anticipating who's going to require palliative care in humanitarian crises, since there are so many intersecting factors. First of all, there's often no morbidity rates or morbidity and risk factors being documented in many low and middle income country contexts on a regular basis. So that can make it difficult to identify who perhaps is receiving some kind of high intensive technology attention or has many chronic comorbidities. And then of course there's issues of access to healthcare centers, which can make a huge difference in terms of somebody being able to access curative options, but if they can't get, because a bridge has been washed out, roads have been washed out, or maybe they don't have the mobility to get to care, then that could actually make them a patient who becomes palliative. Also, depending on what resources are available, people could get triaged out of care. So there's just so many reasons that it can be complicated, but at the same time, what is clear from the literature is that there has not been kind of regular assessments and tracking of who is receiving palliative care in humanitarian crises. Three big confirmations that we have heard from colleagues working in the field and on the front lines of humanitarian healthcare that are confirmed in the literature is that there is a lack of guidance, guidelines and training, or there certainly were by the time our search ended in 2017, so things were just starting to emerge in terms of guidance, but there's definitely a lack of training, which causes a lot of moral distress, causes healthcare providers to have to kind of decide on their own how to manage these situations and patients. It's lived as suboptimal, so that hooks up to the moral distress. If there's any kind of palliative care provided, what's consistent in the literature, often written by healthcare providers, returning and writing commentaries, or starting some research, is that it could be and should be better. So it involves improvisation and adaptation, which is important as well. Some people are recommending policies and guidelines, but the majority are recognizing that you're going to have to constantly reassess in a humanitarian crisis, depending on how close you are to the initial disaster. Resources come in and out, populations in need will vary. Also confirmed in the literature is the challenge of access to opioids in many contexts and the need for more opioid access. So three big recommendations is that basic EOL care training for all would be ideal. So rather than have specialized teams, perhaps everybody should be better prepared for these situations. Earmarking resources for palliative care was mentioned by a number of authors. And culturally sensitive care is perhaps the item that the recommendation or nuance that is emphasized the most in the literature is that no matter what's happening, make sure that you're working with local providers, figure out what people need. Patient-centered care and good care is going to have to be culturally sensitive. So then the question is, are the recommendations actionable? So we can be thinking about that today.
Well,